So we have Dr. Lou Posey, who is working his way through the sports service and is going to talk to us about radial head arthroplasty for radial head fractures. Go for it, Lou.
Awesome. Thanks for the introduction, Dr. Pat. So good morning. For those I have not had the chance to meet yet, my name is Lou Posey and I'm one of our PGY2 residents. Today I'd like to discuss where we are at currently with radial head arthroplasty for radial head fractures. My only significant disclosure is that I am active duty Air Force, thus I am required to state that the presentation today only reflects my own views and understanding of the topic and not necessarily those of the U.S. Air Force, Department of Defense, or the U.S. government, though I doubt they'll care. While I cannot give nearly as eloquent of a talk as Dr. Seacrest did last week regarding the evolution of bipedal ambulation and its orthopedic manifestations, we will start out reviewing why this topic is important, discuss some pertinent anatomy, and then review the history of radial head arthroplasty. Then we will get into the current indications and technical pearls of the procedure with a subsequent focus on outcomes in the literature, and then finish off with some of the featured directions and exciting unanswered questions. So why should we all be interested in this topic? Well, we can all agree that radial head fractures are common, as they make up nearly a third of all elbow fractures. And they're associated with other injuries that are outside the scope of this talk, but worth noting as we take care of patients with radial head fractures, as our ultimate treatment plan will usually require consideration of various ligamentous injuries as it pertains to restoring elbow stability. With a radial head fracture, surgery is considered if there is significant articular displacement, a mechanical block to motion, and/or unstable fractures associated with other ligamentous injury combinations. And in terms of surgical treatment options, we can repair fixable fractures, excise the radial head entirely, or replace the radial head. And that is what's more interesting is the increasing trend of this replacement option being seen in younger and younger patients. This is actually a 13-year-old girl who ended up with a radial head arthroplasty, which was the youngest I found in my review of the literature. So this begs the question of what the long-term data shows for this treatment option and highlights why this is an important topic for anyone caring for patients with radial head fractures. So during one of our anatomy lab sessions with Dr. Mormon, he shared with us this quote from one of his mentors, and I thought it was very appropriate for this talk. He said that great orthopedic surgeons are a combination of two things, an in-depth knowledge of anatomy and a large dose of common sense. So with that said, let's discuss some of the important anatomy. When looking at the articular surface of the radial head, one can appreciate that it is not truly a circle and is actually more elliptical in shape. Although there is considerable variability with radial head shape and offset from the radial neck, the head has a greater radius of curvature than the capitellum, making it only a moderately constrained joint. A lateral view allows you to appreciate that it is also a concave dish with two primary articulating surfaces. One is with the capitellum that we were just discussing, and the other is with the radial notch of the ulna. Here's a look at that saddle-shaped articulation of the radiocapitellar joint. It allows for elbow flexion, extension, and forearm rotation. And then we also see the proximal radial ulnar joint that is constrained by the annular ligament in this photo that allows for rotation of the radial head in the lesser sigmoid notch of the ulna. Now, a couple of points about this articulation with the radial notch. One is that there is a 110-degree arc that does not articulate with the radial notch, and it is centered upon a point that's just 10 degrees anterior to the midpoint of the lateral side of the radial head. And this is the safe zone for hardware placement in the event that there is a fixable radial head fracture. And if you're as bad as math as I am, this can also be estimated as the rotational interval between Lister's tubercle and the radial styloid. So ligamentous anatomy is very important in understanding elbow biomechanics. The lateral ulnar collateral ligament and the radial collateral ligament are the primary stabilizers to prevent varus and posterolateral rotational instability of the elbow. And to highlight this concept, this biomechanical study looked at sequential sectioning of the radial collateral and lateral ulnar collateral ligaments, and then the LCL, which is what they defined in their study as the combination of the radial collateral ligament and the lateral ulnar collateral ligament. And what they ultimately showed is that once the entire LCL was transected, there was significant posterolateral instability and varus laxity of the elbow. Now that's for varus and posterolateral stability, but the radial head is also an important valgus stabilizer of the elbow. This classic biomechanical study by Morey showed that after cutting the medial collateral ligament, the radial head is a key secondary stabilizer to valgus stress. In terms of transmission of force and load sharing across the elbow, the radial head transmits roughly 60% of the force based on this biomechanical study, and maximal force is seen in elbow extension and pronation. But what about longitudinal forearm stability? Well, this biomechanical study showed that in the setting of a radial head excision and interosseous ligament injury, radial shortening occurred, which increased forces on the distal ulna and helped explain a lot of the increase in ulnar-sided wrist pain seen in these patients. But restoring original anatomical length of the radius with the insertion of a metal implant maintained distal ulnar forces at normal levels in all wrist and elbow positions. This study also showed that silicone radial head replacements were inferior to metallic implants for restoring that axial and valgus stability. Now, turning our attention back to the radial head fractures, the Mason classification defines a type 1 radial head fracture as non-displaced or displaced less than 2 millimeters with no blocks to rotation. This is typically managed non-operatively. Type 2 fractures include marginal fractures with displacement, and type 3 fractures display comminution that involve the entire radial head. And then later, Johnson et al. Added a fourth type where there's a radial head fracture and an elbow dislocation. So that was a brief overview of the pertinent anatomy. Now let's see how the common sense played out over history for these type 3 and type 4 fractures that typically are an indication for radial head arthroplasty when there is an associated ligamentous injury. So I'm going to start our brief recap at the beginning of the 20th century, where in 1924, Speed stated that in adults, unless the lesion is only a mere crack, there is no doubt that removal of the head is primarily indicated. Later on in 1939, there was the beginning of a change of philosophy as the dogma was questioned. And Dr. King mentioned in his case series that it had been taken for granted in too many instances that the procedure of a radial head excision was harmless and free from undesirable complications. So then in 1941, Speed was the first one to recant what he said earlier and change his prior belief and describe the use of these Vitalium caps, which came in 6, I'm very sure, inconvenient sizes with the intent to prevent HO formation. But the study also showed that there was an observation that the caps prevented shortening of the proximal radius. So things were really starting to make sense. But unfortunately, the 6 sizes did not fit all, and the long-term outcomes of these caps ended up showing decreased pronosupination. And then in 1951, Essex-Lopresti et al. Started suggesting the use of radial head implants in cases where there was a DRUJ or interosseous membrane injury that occurred in conjunction with a radial head fracture. Beginning in 1968, Swanson developed this elastic implant with a low elastic modulus to allow for easy implantation and a smooth surface. However, there were reports of early mechanical failure as the implant did not provide sufficient resistance to axial load, which makes sense based on how flexible it appears there. And there were case reports of severe inflammatory arthritis with reactive giant cell synovitis. So these were a no-go. Then in the 1980s, we had a revolution of our understanding of elbow biomechanics, which included some of those previously mentioned studies by Mori et al. And others that we talked about previously. Conveniently, in this decade, there was also more literature to support the logical complications of instability being seen with radial head excision to include HO formation, wrist pain that was ulnar-sided, valgus instability, proximal migration of the radius, and post-traumatic arthritis. So this revolution of knowledge led to the generation of multiple metallic implants once silicone was found to be inferior. And this came with both bipolar and monopolar designs, many of which had good short-term outcomes with restoration of radial length. But remember, the radial head is more elliptical, as we discussed earlier, and these designs were very much circular. So they found altered kinematics and radiocapitellar stability. And this is what led to the evolution of more anatomic implants in the 21st century, with the earliest being released by Acumed in the early 2000s. And since that time, more anatomic radial heads have been released by other companies to include other long stem designs for more comminuted proximal radial head fractures. A more recent biomechanical study in 2015 showed that these more anatomic radial heads had better contact area with the capitellum, and thereby had decreased contact pressures during compressive loading. But at this point, we didn't have any clinical studies to show if this is clinically significant. So to simplify all the options into a way that my simple brain could understand, there are really 2 schools of thought today. There's a rough and tight approach with rigid fixation, or a loose and smooth approach with a polished stem that is really just meant to act as a metal spacer. But with our new knowledge of elbow anatomy and biomechanics, that indication for arthroplasty can be redefined and really should be considered for the non-reconstructible radial head fractures in the setting of an associated injury to the medial or lateral collateral ligaments or the interosseous membrane. So here was a paper that actually evaluated the incidence of associated ligamentous injuries for the Mason type 2 and type 3 radial head fractures with MRI. They found that 80% had disruption of their lateral ulnar collateral ligament, and about half the patients had disruption of both the LUCL and the medial collateral ligament. With all that said, let's now discuss some of the pearls of radial head arthroplasty that use anatomy and common sense. First is to piece together the radial head on the back table. And remember, it is likely elliptical when you put the puzzle pieces back together, so choose the size based off the minor diameter of the reconstructed radial head, or when in doubt, guess the slightly smaller one. And then next, select the radial head prosthesis that allows it to articulate at the level of the proximal radial ulnar joint, which is about 2 millimeters distal to the coronoid. Over lengthening leads to the altered elbow kinematics as discussed previously, and usually leads to earlier arthritis and loss of elbow flexion. This was an interesting study that evaluated the difference between clinical evaluation of the ulnohumeral joint line versus radiographic detection of over lengthening. In this picture on the bottom left is the correct anatomic length for a native radial head versus the clinical visualization of the gap at that lateral ulnohumeral joint with just a 2 millimeter increase in size. But the importance of this study was they actually showed that incongruity of the medial ulnohumeral joint on X-ray only really becomes apparent after you've over lengthened by 6 millimeters or greater, as shown here, versus the clinical photo, which is even more obvious. Thus, the authors creatively recommended the use of a dental mirror to assess the lateral ulnohumeral joint during surgery to prevent over-lengthening. And then lastly, of course, it's recommended to repair the lateral collateral ligament complex if it is injured during the case. So now let's discuss some of the outcomes of radial head arthroplasty. This study by Marsh et al. In 2016 is one of the best quality, with 55 patients that were retrospectively reviewed after receiving a smooth-stemmed modular metallic radial head implant. There was a mean follow-up of 8 years and good to excellent outcome measures. Although there were no revisions, 45% did show radiographic evidence of stem lucencies of unknown clinical significance. 38% had ulnohumeral arthritis, 36% developed heterotopic ossification, and 2 patients did end up undergoing a secondary elbow surgery. Popovich et al. Investigated the outcomes of bipolar cemented implants in 51 patients, and they reported a mean follow-up of roughly 8.5 years, with most patients having good to excellent outcome measures. But they found that 37 patients had evidence of osteolysis at that bone cement interface, with pain increasing as the osteolysis became more severe. Thus, they ultimately advised that the cemented bipolar implants only be used with caution in young active patients. This more recent systematic review in 2016 included 30 studies with over 700 patients, and they actually had a nice spread of different combinations of implant types and fixation methods. But there appears to be good to excellent results in 85%, with no difference found based on implant design, except the silicone ones, which obviously still failed, but that makes sense to us at this point. A recent meta-analysis in 2017 set out to define the minimum follow-up required to analyze complications, and they found a reoperation range between 0 and 45%. But ultimately, they concluded that the literature was fairly weak and unreliable for estimating the true reoperation rate, with 90% of the data having insufficient follow-up. Nonetheless, they did highlight some of the top reasons for reoperation, which was helpful, to include painful loosening, stiffness, and complications of over-lengthening. This study compared press fit to smooth stemmed, or the intentionally loose fit implants for almost 3 years of follow-up, and they found no significant difference with the exception of noted osteolysis in that press fit cohort. And it's not hard to extrapolate where this osteolysis could ultimately increase the risk for fracture. So this was a fairly similar study performed out of Quebec that actually showed a difference in range of motion with a significant loss of flexion in the porous or press fit group. And their rationale for this finding was that the smooth implants adapted better to elbow kinematics. So this brings us back to our 13-year-old with the radial head implant. What can we tell mom at this point about its longevity? At this time, 90% of the literature does not have great follow-up, and we really don't have any prospective trials that compare head-to-head implant designs, pun intended. While lots of data looks at outcomes of primary radial head arthroplasty, the literature of revision radial head arthroplasty is not well studied, and little is known about these outcomes, complications, or survival. And this is actually a topic our institution is looking into currently, so stay tuned. And as an aside on the topic of endurance, I highly recommend this book, Endurance, for a fun read about the adventure of Ernest Shackleton's trip to the South Pole around 1914. It's an amazing story and a real humbling reminder that most of us live a very comfortable life. I'd like to give a special thanks to Dr. Loeffler, Dr. Ford, Dr. Coe, Dr. Gass, and Dr. Hammond for their support for this presentation. And I definitely want to thank my class for being an unending source of motivation and fun. Looking forward to the next 4 years, guys. Here are my references. Thank you all for listening, and I'll open up the chat for questions.
Great, thanks. Awesome stuff, Lou. Would welcome everybody to turn their cameras on and open to some interaction and discussion. I see a bunch of our elbow surgeons online, as well as some of our trauma surgeons. Any comments on the content?
Lou, this is T. Great talk, and I really appreciate you highlighting the importance of anatomy. And we've got great resources for this here with our Fresh Tissue Lab and our alignment with Arthrex and some of the other companies. So this would encourage all the residents to really take advantage of those resources.
That was a really good summary, Lou. It's Brian Loeffler. I think you covered a lot of important topics there. I think there's still some controversy with the radial head. Are we trying to create a real anatomic replacement? A lot of the newer designs have attempted to do that. But I've found in our literature really has shown that the more simple philosophy of just using a radial head as a spacer, again, to limit the axial load and stress on the interosseous ligament and at the distal radial ulnar joint, as well as to protect your ulnar collateral ligament of the elbow, is really all that seems to be needed for the radial head. That design really allows it to be more forgiving and kind of find its place with elbow motion, which includes rotation, inflection, and extension, as opposed to putting something rigid in that if it's not just perfect, it's actually going to create more stress. And as you showed in that slide, that's where you get more of the osteolysis and failure of ingrowth, and that's where you get real thinning of the cortices, and you can see problems where they get pain from movement at the radial head, and they can even get periprosthetic fractures, which I've seen as well.
Yeah, this is Larry Kempton. The other point I'd make, which kind of comes from your literature review, which was great, is that I've heard on at least several occasions at meetings, most often conferences with attendings presenting to residents with case presentations saying, well, in this particular patient, they were younger, so I decided to fix the radial head instead of replace it. And they don't really say why they consider that, but as you've shown, there's not great literature supporting better outcomes with fixing radial head fractures in certain situations. The thought is more of, well, if I can fix it, then because I don't know what the true long-term outcomes of radial head replacement are, then maybe it's better just to restore the patient's anatomy. So I think one of the points for residents is that if you think a radial head can't be reliably reconstructed, maybe it is okay to just replace it despite a patient being younger and more active. I think it's just a matter of not knowing.
Couldn't agree more. Thanks, Dr. Kempton.
Hey, it's Natty. Yeah, I agree with a lot of Dr. Loeffler's comments on this. It'll be interesting to see where we go with the press fit anatomic design. I don't know how long they'll be around. I know I've heard Sean O'Driscoll, who is the designer of one of the more popular ones, give a talk about it and the learning curve, and he still has by his own admission, a high complication risk with the anatomic press fit design. I heard recently that one of them was just pulled off the market as well in Europe for high reoperation rates. So I don't use them. I don't like the philosophy of it. I think it's it may sound a little pessimistic, but I think it's really not possible or very, very difficult to properly reproduce that anatomy. And you're almost doomed to lead to maltracking and postoperative symptoms for the patient with that design selection. So I've always gone with the space filler philosophy with these, and it can be a great result. I've done a lot of young patients too, and it's a fairly predictable operation. You do see radiographic changes over time, but I have not seen that correlate with clinical outcomes. So I wonder where we'll be with those anatomic designs in the next 5 or 10 years.
Awesome. Thanks, Dr. Hammond. Appreciate the comments.
All right. Well, thank you, Dr. Posey and Dr. Braswell, for some great talks this morning. And I did post in the chat, if anybody wanted to see those, the links for both the YouTube video and the article that Dr. Braswell mentioned during his talk. We will look forward to seeing everyone back next week. We will have, well, I guess not everybody. We're going to have an M&M conference next week, so we'll have a more limited attendance for that on the pediatric service. So look forward to seeing everybody next week, and everybody stay safe and get to work. Thanks. Bye.